laparoscopy is the panacea for all abdominal surgeries. For those who are not familiar with the geography, especially those who are coming to India from overseas, I am coming from Sri Lanka, island in the Indian Ocean, which has a lot of beautiful tourist attractions, and the total population of the country is about 23 million, very much less compared to India. This is where I work since 2006. It is directly linked. This is Colombo South Teaching Hospital. This is directly linked to the Faculty of Medical Sciences of the University of Sri Jayawardena. And I'm sure there are many members in this audience who have visited this hospital, and I can still remember as a surgical trainee in 2006, I was assisting Dr. Palani Velu to perform first laparoscopic cardiomyotomy in this hospital. Since then, we have come far away, and now we are a tertiary referral center for advanced laparoscopic surgeries. Not only that, we perform advanced therapeutic endoscopies and ERCPs. In contrast to India, most of the surgeons do endoscopic as well as ERCP procedures. Prestigious, well-known figures from India, Hyderabad, Dr. Nageshwar Reddy has also visited several times to this hospital to conduct several workshops. The aim of this oration is to tell you whether the laparoscopy is a panacea for all abdominal surgeries. In achieving this objective, I would also discuss briefly how the laparoscopy evolved over the past. What are the advantages of laparoscopy as well as disadvantages? Are there any hazards of laparoscopy to the surgeon, to the patient, and also to the environment? And most importantly, what are the factors one should consider in deciding the best surgical approach for a particular patient? And is it possible for us to conclude that laparoscopy is a panacea for all abdominal surgeries? When we look at the history of laparoscopy, as you all know, in 1805, Philip Bossi developed an outward system of candles and mirrors to examine canine bladders. Almost a century later, a Swedish surgeon, Hans Jacobs, is credited for coining the term laparoscopy into our vocabulary. Laparoscopic concept crossed the borders between diagnostic medicine and therapeutic surgery thanks to this pioneering surgeon and gynecologist, Professor Ket Sem, whose family owned a manufacturing company. And according to his ideas, several hand instruments that we use today were developed in this institute. Then later, in 1985, I would call the medieval history of laparoscopy. Professor Eric Mu performed first laparoscopic cholecystectomy. Although, as you all know, Philip Morey, the gynecologist, has been frequently cited as having performed the first procedure. Then gradually, laparoscopy became very popular, with lots of obstacles erupted in places where there were surgeons who were very reluctant to take up this new technique. As we all know, there are tremendous developments in technology, especially fiber optics, over the last few decades. This had huge impact on laparoscopy as well as endoscopic surgery, with a considerable cost involved in establishing the facility in our part of the world. Despite that, we should be very proud that we have produced best surgeons in laparoscopy in this region of the world. With regard to the technology, from the days of development of telescopes with rod lenses, we have come a long way. And now we have flexi telescopes with 3D and 4K technology with IR imaging. For example, it has been shown that with IR imaging, we can now predict the chance of leaking bowel anastomosis. Not only that, not only the fiber optics, hand instruments have also been developed trying to match the movement of the human hand. Also, methods of access have been developed. from Beres needle and open Hassel technique to usage of optical ports. In addition, the multiple ports of access, we have now gel ports and SILS ports. As you know, it is a different terminology we use now. Laparoscopy is also called minimal invasive surgery. But we know that if the surgeon is not well trained, that can be maximally invasive. Therefore, I think popular terminology is minimal access surgery, which includes laparoscopy as well as endoluminal procedures, nodes and robotic surgery, which I am not going to deal in detail during this talk. However, I do not think it is justifiable to use the term minimal access surgery for laparoscopy. As we all know, it is not minimal access, but we have maximum access when we do laparoscopy. We can have very good access with magnified view to difficult areas of access, like difficult male pelvis in ultra-low anterior sections, for example. Therefore, Chairman Sir, I would call it small incision surgery, not minimal access surgery. It is a maximum access surgery through limited incisions. Good old days, people said, big surgeons make big incisions, but now we know better surgeons make small incisions. And I'm not surprised in future, people will also say best surgeons make no incisions during their surgeries. Before going into the core content of my talk, let's see why we do laparoscopic surgery. We perform laparoscopy because we know there are certain definite advantages to our patients. But some would argue that it is not much of a difference in certain diseases when we do laparoscopy or surgeons with gifted hands also perform major complex procedures laparoscopically as well. But can we recommend laparoscopy to all abdominal surgeries? Mr. Chairman, that is our question in hand. Before making this decision, let us see what are the advantages of laparoscopic surgery. There are advantages to the patient, advantages to the surgeon, as well as advantages to the healthcare institute. Less pain, fast recovery, therefore early return to normal life are advantages to the patient. Not only that, we know with laparoscopy, long-term adhesions are very much less, and adhesion-related complications are going to be less. Because of less lengthy incisions, the chances of surgical site infections are less. Therefore, chances of incisional hernia rates are less. How about the surgeon? For the surgeon, the laparoscopic procedure is ergonomically comfortable. Surgeon does not have to struggle with assistance for retractions. Best examples are deep pelvic dissections, adrenal surgery and bariatric surgery, where we use gravity as our main force of retraction. A lot of training opportunities are also available to the surgeon compared to open surgery. Number of learning material available are much more when we compare to open surgery. When you are more experienced, more patients will come to you. Therefore, it's financially more lucrative to the surgeon. What about the healthcare institute? Even though the initial investment is high, in long term, more profitable to the hospital because of the less hospital stay, the more patients will turn over, and also patients will pay more to the hospital because of the fast recovery, because of less pain and less surgical scars. However, as we all aware, there are many disadvantages of laparoscopic surgery. When we know high initial cost, complications associated with laparoscopy at entry, during surgery and during recovery. These are all disadvantages. I'm not going to deal in detail about these things. However, Mr. Chairman, now the question comes whether it's worth doing laparoscopy when long-term outcomes are the same. This Cochrane review shows that there is no difference in mortality, complications, and operative time between laparoscopic versus open cholecystectomies. However, we know that laparoscopic cholecystectomy has a higher incidence of common bile duct injuries. But I am sure with the training, more and more young energetic surgeons will have more experience on this area and is going to be safe with open surgery. When colorectal surgeries are concerned, it is also the same. There is no difference, according to this trial, in disease-free survival, whether one do open or laparoscopic colonic resections. Now, Chairman sir, I will come back to the same question. Is laparoscopy panacea for all abdominal surgeries? Is it safe to do, or is it practical to do laparoscopy all the time? I will try to answer this question with published data at our hand. This review was published in British Journal of Surgery, analyzing bowel injuries as a complication of laparoscopy. It has shown about 0.2 to 0.3% bowel damage during laparoscopy. Out of that, about 0.22% are perforations and about 0.13% are partial injuries. More injuries has occurred to small bowel, and trocars and Weller's needles are the culprits of bowel injury, while about 25% of the injuries are due to energy devices. More importantly, I want you to understand that out of all the injuries, about 68.9 patients had associated adhesions or laparotomies prior to the index laparoscopic procedure. It is also associated with 3.6% of mortality. This paper came from British Journal of Obstetrics and Gynecology, analyzing more than 25,000 gynae laparoscopic procedures. They have recorded about 0.57% overall complication rates. Out of that, 57% caused at the entry, and overall 58% needed laparotomy. When there is vascular injury, the necessity for laparotomy went up to 90%. Let's see intraoperative complications during laparoscopic colorectal resections. What is the impact of the learning curve to the outcome? This was published in the Disease of the Colon and the Rectum in 2001. Total number of 461 patients were analyzed. 90% of them were operated during the learning curve among 3 surgeons. There were no difference with reference to the demography, the disease pattern, and the complexity of surgery among 2 groups. It was reported declining overall intraoperative complications rates from 9 to 7%. Although it was not statistically significant, I am sure I would say that as far as the patient safety is concerned, it is quite significant. It has also shown declining conversion rates from 13.5 to 9.7%. It was demonstrated that learning curve for the right side resections were about 55 cases and the left side was about 62. In addition, it was shown that readmission rate and post-operative complication remained unchanged throughout the series and was not dependent on operative experience. However, ladies and gentlemen, Mr. Chairman, these are statistical analysis. I am in the opinion that when it comes to clinical practice and patient safety, operator experience is one of the most important factors we have to consider. And when a surgeon becomes more and more experienced, he or she selects more complex cases. And for those cases, conversion rates may be high, and unless one makes adjustments accordingly to the complexity, that may not reflect in the final analysis. This study clearly demonstrated that after adjustments made for confounding factors, there are 5 independent predictors of conversion to open surgery, namely ASA grade, higher the grade conversion rate is high, body mass index, which has direct proportion to the conversion rate. Left colonic resections have more chance of conversion than the colonic resections on the right side. It is about 15.3% to 8.1% respectively. When there are intra-abdominal abscesses or fistulae, again the conversion rate is high and operator experience is inversely proportionate to the conversion rate. What are the conclusions that we can arrive at this stage of my presentation? Number 1. Technology facilitates laparoscopy more than open surgery. Number 2. More training opportunities and methods are available for laparoscopy. Therefore, we will have more and more young, energetic, technically competent surgeons who will take up more advanced laparoscopic procedures in future. There are diseases for which laparoscopy has become the treatment of choice. Laparoscopy offers many advantages to the patient, surgeon, as well as to the healthcare institution. All of these favor doing laparoscopy for more and more abdominal surgeries. But there is one factor which stands out of all to say laparoscopy is safe for all abdominal surgeries. That is none other than patient safety. To explain this fact, let's imagine a hypothetical situation where there is a patient with high ASA grade and high BMI for sigmoid colectomy for colovesical fistula due to diverticular disease. Surgeon is in his learning curve who has done about 50 left colonic resections. On that particular day of surgery, the surgeon's senior registrar, who is a regular assistant to him, is on leave, and the consultant anesthetist is also new to the hospital. If you are the surgeon, what decision would you make? In this situation, my decision will depend on not by my ego, not by peer pressure or hospital pressure, not by statistics certainly, but purely considering patient safety. I will decide to do laparotomy. Especially if this patient has had previous laparotomies, then the chances of adhesions are much more, and chances of bowel and vascular injuries are high at the entry if you are planning to do the surgery laparoscopically. Ladies and gentlemen, what are the debatable areas for laparoscopy at present? What is the situation in trauma and emergency? In a recent Danish review done in 2017, an unselected group of major abdominal emergencies were analyzed. It was reported a low rate of complications in operations conducted by initial laparoscopic approach. However, it shows high rate of conversion to open surgery, with 10% of the entire study population obtaining the benefit of laparoscopic approach. But what is the information that we can get from this study? This shows that the laparoscopy is slowly stepping into and establishing its position in major abdominal emergencies. Let's go through some examples like acute small bowel obstruction, perforated peptic ulcers, diverticular disease, and look into the evidence to see the place for laparoscopy. Let us discuss about acute small bowel obstruction. In this review article, results of 29 studies were analyzed. The laparoscopic approach was attempted in 2005 patients with acute small bowel obstruction. As expected, adhesions were the most common cause of etiology for obstruction. It was about 84.9%. Laparoscopy was completed in 64% of the cases, while 6.7% were lap assisted, and the conversion rate were 29%. The overall mortality and morbidity of laparoscopic small bowel obstruction is 1.5% and 14.8% respectively. These rates are lower than those published for open surgery for acute small bowel obstruction. But as many studies did not record age or ASH grade, predictors of mortality and morbidity were not analyzed or determined during this study. The overall conversion rate, as I mentioned before, to midline laparotomy was 29%. Dense adhesions, the necessity for bowel resection, unidentified pathology during laparoscopic assessment, and iatrogenic injuries accounted for majority of the conversions. What we can gather by reading this article is that there is a place for laparoscopy in acute small bowel obstruction, but it has to be done by a well-experienced surgeon to minimize complications. With our experience, we know it is more effective in patients with relatively simple adhesions or single band causing small bowel obstruction by relieving it by doing laparoscopy. What is the situation in perforated peptic ulcers? Laparoscopic repair of perforated peptic ulcers has now been performed by trainee surgeons with acceptable results. In recent review by Chung K et al., it was recommended that strict selection such as boys go 0 to 1, ulcer less than 10 millimeters, and ulcer located in the pyloroduodenal area in a hemodynamically stable patient with no previous abdominal surgeries, and when one is not suspecting a malignant ulcer and the patient's ASA grade is 3 or less, it was considered safe for laparoscopic approach in treating perforated peptic ulcers. What is the place in laparoscopy in complicated diverticular disease? 25% of patients after 60 years develop diverticulosis, especially in the West, and quarter of them develop diverticulitis, out of which 5% develop complications. I repeat, especially in the West, 25% of patients after 60 years develop diverticulosis, and quarter of them develop diverticulitis, out of which 5% develop complications. These are the 3 trials compared laparoscopic washout and drainage versus primary resection in complicated diverticular disease. A conservative approach using laparoscopic peritoneal lavage and drainage has been analyzed in recent years in these 3 clinical trials. Dilshan trial conducted and concluded that it is feasible and safe to do laparoscopy in complicated diverticular disease. However, numerous subsequent trials, Scandiv and Ladies trial, did not show added benefit in the laparoscopic approach in complicated diverticular disease. In fact, Ladies trial terminated early due to increased adverse events in laparoscopic arm. Hence, in 2016, World Society of Emergency Surgery guidelines recommended that laparoscopic peritoneal lavage and drainage should not be considered as a treatment of choice in patients with generalized peritonitis due to diverticulosis. What is the position in laparoscopy in trauma? Laparoscopy has been attempted as a diagnostic tool in trauma patients, provided that they are hemodynamically stable. Laparoscopic surveillance has been shown to reduce the negative laparotomy rate in trauma. Although some studies have shown promising results on the use of laparoscopy in blunt abdominal trauma, randomized controlled trials are lacking in this field for obvious reasons. This paper was published in year 2002 and came from USA. Laparoscopy has been slowly attempted as a diagnostic tool for such patients, provided that they are hemodynamically stable. Under these circumstances, laparoscopic surveillance has been shown to reduce the negative laparotomy rate. Since then, there were many studies showing its place in trauma. Similarly, one should not attempt laparoscopy but go for laparotomy if the patient is hemodynamically unstable and if there are associated intracranial injuries. Also, laparoscopy should be done cautiously if the patient has got associated high-grade chest trauma or pre-existing intra-abdominal adhesions or in case of pregnancy. While doing laparoscopy in emergency, chances of needing laparotomy is high when there are dense adhesions, if the bowel ischemia is suspected, and one cannot identify the pathology in laparoscopy. Is that all we have to consider in decision making and selecting the mode of surgery for a particular patient? Ladies and gentlemen, I do not think so. What are the environmental impact in laparoscopy? When laparoscopy is widely used without our knowledge, are we contributing to the greenhouse effect? This paper came from USA, which is the second highest producer of carbon dioxide emission in the world. They estimated that the healthcare sector contributes 7% of their entire carbon dioxide emission in the US, out of which only 0.1% that has come from minimal access surgery. That amounts for 355,621 tons of carbon dioxide per year. As you can see in this, you can appreciate how much of direct carbon dioxide consumption has gone up in the period from 2006 to 2010, which is considered as the period where laparoscopy became very popular. Mind you, this is only the operating room consumption. This shows the amount of carbon dioxide released at each procedure. The total direct carbon dioxide emission is about 303 carbon dioxide tons per year. But if one considers the indirect carbon dioxide emissions, that is carbon dioxide capture and compression, transportation, incineration of trocars and other disposable material, etc., it is 355,621 tons of carbon dioxide per year. What is this amount means in lay terms? This is equals to the carbon dioxide emitted by driving a medium-sized car 80,000 times around the earth at the equator. When considering both direct and indirect factors, there is a significant environmental impact. Mind you, this is only in United States. So with increasing usage of laparoscopy, we can understand how much we are damaging the environment. How about the damage to the surgeon? Laparoscopy is more stressful to the surgeon and the team than open surgery. This paper highlighted this with evidence. It says laparoscopic technique requires greater concentration and place greater mental stress on surgeons than open surgery. This paper highlights the physical injuries that surgeon may suffer as a result of laparoscopic surgery due to non-adherence to the principles of ergonomy during laparoscopic surgery. Mr. Chairman, ladies and gentlemen, for the sake of laparoscopy, we don't want to contribute to global warming. No, we need handicapped surgeon. When the surgeon is handicapped, we know that anesthetist is also getting handicapped. Or more importantly, morbid patient in return of proposing laparoscopy to all abdominal surgeries. Ladies and gentlemen, now I have highlighted the strengths and limitations of laparoscopy. The most important thing is to decide on what to do when your patient is in front of you. That decision should not be influenced by surgeon's ego, peer pressure or institutional pressure, or patients or relatives' demands. This decision should be based on the skills and the capabilities of the surgical team. This should be also based on facilities available at the center and also patient factors like comorbidities, BMI, patient's past surgical history, and disease condition of the patient. Most importantly, one should consider none other than patient safety in deciding the suitable mode of surgery.
whatever statistics say, when we make a decision in treating patients, there are fundamentals that we should adhere. Number one, the patient or the surgeon should be a sensible one or should have common sense. Number two, surgeon's awareness of the level of his and hers or her skills should be very important. Surgeon should be prepared to re-skill himself and also to upskill him or herself so that he or she should be able to take up more advanced, newer techniques in their clinical practice. It is also important that surgeon is aware about the ability of his or her team, and also surgeon should be very aware about the available facilities in the hospital in case he has to use them in emergency situations. Out of all, as I mentioned before, patient safety has to be considered a paramount importance in surgical decision making. The territory for laparoscopy in the abdominal surgeries has widely expanded in the recent past, as I have shown to you with evidence. From elective to emergency and to trauma, laparoscopy has its own place. Acquiring the skill, improving it further, and developing new skills by the surgeons will definitely widen its scope. However, the term laparotomy will remain in our vocabulary during the 21st century. Once Sir William Osler said, I quote, "People do not die of their disease, they die of their pathophysiological effects of the disease." Unquote. Mr. Chairman, ladies and gentlemen, as healthcare professionals, no one knows how much we contribute to these pathophysiological effects, but I assume it is a significant proportion. I hope all of you would agree with me that for the sake of laparoscopy, we should not add more and more to these pathophysiological effects. Thank you very much.